Yeah, so this is where we ended off last time. And as I was saying, when you take a chest X-ray, you should be able to easily identify some of these structures that are listed in here. A few of them of note, the important ones here, for instance, the trachea. If you look at this X-ray, you can see that there's some translucency within all this opacification here. So things to note are that when it is white, we say it is radio opaque. When it is dark, we say it is radiolucent. Okay. So there's some radiolucency within all this opacification here. Okay. So that is what we see over here, and that is the trachea running through. And if you see, you look critically, you see that the spinous processes are shown here. So this is one spinous process. Let me do my highlighter. Okay. So we see over here the spinous processes that the liver. I said the dark thing running through all of these files is the trachea. The clavicle is the one here. There's one on the left, there's one on the right. And this is what I mentioned that we use to determine whether the trachea is central or not. I mean, whether the person was well positioned or not. So a lot of structures, the ribs are showing here. The outline of the heart can be seen, the diaphragm, the right diaphragm, the left diaphragm. Either one is called hemidiaphragm. So the right hemidiaphragm, the left hemidiaphragm. A very important part that you need to take note of on X-rays are the costophrenic angles. Costo means ribs, phrenic means diaphragm. So angle between the ribs and the diaphragm, that's a costophrenic angle. So this corner here, where this diaphragm is meeting this ribs here, is called the costophrenic angle. There's one on the left, there's one on the right. They are very, very important because they help you to be able to tell whether there's pleural effusion. The main importance of costophrenic angles is that whether there's pleural effusion, as well as the cardiophrenic. So the angle, the heart. Can you see the outline of the heart here? Can you see my Keza?
Yes, Doc.
Okay. So the angle that the heart forms with the diaphragm is called the cardiophrenic angle. So the ability to see them clearly means that there's no effusion on this X-ray. Then also another very important thing we use to look for the heart, the stomach is the gastric bubble. So you can see some radiolucency under the left hemidiaphragm, and that is the gastric bubble, Now, whilst we are here, I would like to mention a certain phenomenon where when there is fluid in the abdomen, you will see it, there's air in the diaphragm, such as in typhoid perforation or duodenal perforation. You see that gas, you can see that the right hemidiaphragm, under the right hemidiaphragm is what structure is under the right diaphragm? Somebody. Yeah, somebody. What's under the right diaphragm? What organ is there? Hello, are people in the class?
Say the liver.
Liver, yes.
The liver.
We realize that because of that, there's no space or radiolucency showing under the right, the right diaphragm. However, if there's air in the abdomen, a person is standing upright, the air will rise up and come and fill the potential space between the diaphragm and the liver. And when you see that, you'd have to make a diagnosis of air under the diaphragm. It's therefore important to know where the gastric bubble is so that you don't confuse it with air under the diaphragm. So this is very important. Okay. Now, the whole of the mid portion of the X-ray here is what we refer to as the mediastinum. And in the mediastinum here, we know the great vessels that enter and leave the heart are here, as well as what do you call it? The heart itself is here, and the medial aspects of the lungs are all here. So basically, the mediastinum, by definition, is the space between the two lungs. All right. Now, over here also, you can see that this X-ray was taken of a female because you can see the outline of the breast here. So you realize that if I should give you this X-ray to label in an exam, it's not, I mean, it's fair, isn't it? Because, I mean, everything here is quite easy to tell. Okay. So that's about, I'm sure we'll see others on the way. Okay, so we mentioned under penetration, over penetration, so I won't waste time on that. Now, this is a lateral X-ray. So this is a PA view. This is a lateral view. When you take a lateral view of an X-ray, these are the structures that you expect to see. And it's important to have these images at the back of your mind. So when you are looking at an image, you know where to look out for normal structures, so that when they are not there, then you know that this is abnormal. So on this lateral X-ray, you can see here, this here is the sternum, okay? This is the sternum here. This is the arc of the aorta here. Hope you cannot see. This is the right atrium here, like the right ventricle here. And if it is a ventricle, then it means that this is the atrium. This is the left ventricle, therefore this is the left atrium. The vertebrae are also shown here nicely. The trachea again is showing here. So it's important to note some of these structures so that when you are commenting on an X-ray, you'll be able to know where pathology might be. Right. Next thing we want to look at is how to go about reading a chest X-ray. How to go about reading a chest X-ray. So you should have this scheme at the back of your mind. So the first thing when you get an X-ray is to be able to is first of all check the request form itself. Okay, so you look out for the name, the age, the sex. Well, you know, you could take an X-ray and it belongs to someone else, and you giving the person some wild diagnosis and give someone heart attack for no reason. So you have to be able to confirm what do you call it? That the X-ray you're holding is for the person that you intend it to be. Then you move on to the technical aspect, whether the X-ray is even good enough for you to start commenting on or not. You should know whether there's adequate inspiration. We said that if there's adequate inspiration, you should expect to see a minimum of about 6 to 8 of the ribs showing, whether there's centering or not, or there's rotation, and whether it is clearly labeled, asking whether it is AP or PA, and whether there's adequate exposure or not. These are the technical things you look out for before you start talking, so that if it is not, then you know how much emphasis or weight you should put on it. So right from there, the first thing you look out for is the trachea. You look out for the trachea position, whether it is deviated or not, whether it's deviated to the left or right, whether it's obstructed, you should be able to comment on that. Then the heart and mediastinum, whether you comment on whether the size of the heart is adequate, the shape of the heart is adequate, or whether it's displacement, you should be able to know. We'll look at how to calculate the size of the heart to determine whether it's too big. But with experience, if you see a chest X-ray that is on which there's enlargement of the heart, cardiomegaly, with experience, you're able to spot it. However, if it's not that obvious, there's a way to calculate and determine if the heart is enlarged or not. Then you move on to the diaphragms. You talk about whether they are the diaphragms are at the same level or not. Whether there's diaphragmatic fracture and rupture in the rest, we should be able to tell. Then the pleural spaces. This is where I mentioned the costophrenic and cardiophrenic angles. And these are important in diagnosing, for instance, pleural effusions. All right. Yes, so where was I? So then you move on to the lung parenchyma itself. So the lung parenchyma itself, now you are interested in whether it is translucent enough or radiolucent enough or radiopaque, whether the vascular markings and the rest are present, so that you're diagnosing the pathology that might be present on it. For the apices, the mediastinum, go to the hilar regions, whether there are gas shadows or calcifications, whether the breast tissue are present or not, all of these things should be commented on. Whether the bones, there are some conditions that lead to lysis of the bones. You should be able to pick all of these up. All right. Yes, so now we start with, we'll go through them one by one. Now the trachea. I said that when you finish identifying the X-ray, the name, age, sex, and the type of X-ray, whether it's AP or PA, the next thing you want to look out for are the technicalities, whether it is adequate or it is not adequate, underexposure or not, whether there's centering or not. We've talked about how to find out. We told you, we mentioned this time that once you see whether the patient was rotated or not, you look at the distance of the medial ends of the clavicle to the finus processes. We mentioned that, so don't forget that. Then, so when you start interpreting the X-ray proper, the first thing you want to talk about is the trachea, whether it is displaced or not, and that has very valuable information. Now you can see that in a normal chest X-ray, this trachea here, can you all see the trachea on this X-ray?
Yes, Doc.
Okay.
Very well.
Good. So that means that, so this trachea, we can all attest the fact that it is central. It is central, isn't it? Good. Now we are saying that the normal diameter of the trachea in males about 25 millimeters, and that of females about 21 millimeters. Of course, obvious reasons. Males are usually sometimes bigger than female, and we have a higher muscle mass and taking more air and all of that. Okay. So we are saying here on point 2 and 3 that the main things you're interested about in the trachea is to know whether it's displaced. And this displacement will give you a lot of information. If it is narrowed or there are lesions inside it, will also give you some information. So usually the trachea is central coming from the cervical or the neck region. And when it comes below the second, what do you call it, intercostal space thereabout, it starts, when it comes down, it starts to take a bend slightly to the right as it dodges the aortic. This X-ray, can you see this diaphragm here, this trachea here? And see that this trachea is deviated to the right. Can you all see? This is the left. It's labeled here. You can also see left here. And this trachea is moving to the right. Now, there are two reasons why the trachea will be deviated either to the left or right. Either there is something here on this particular X-ray, either there's something here that is pulling the X-ray, pulling the trachea, or there's something here that is pushing the trachea. So whenever you see a trachea that is deviated, then this is the first thing that you want to look out for. Is it being pushed away or is it being pulled towards itself? You get me? All right. Yeah, so it's the same thing here. Trachea and the upper mediastinum is central. This deviation to the left or right could be indicative of pathology. However, we said that when it gets to about this level, it bends slightly to the right to dot the aortic nectar. All right. Now, if you see a deviated trachea, there are a number of things that you think about. If it is being pulled or it's being pushed, then the things that can pull the trachea to their side. That is, if the pathology is on that side, the trachea will be deviated to that side. That is when, for instance, there's atelectasis, or when there's a genesis of the lung. If the lung on that side does not grow or does not grow well, the trachea will move to that side. If a part of the what do you call it? The lung has been removed, by surgically removed for any cancer, whatever it is, the trachea will shift to that side. If the lungs or the pleura are fibrosed, they also pull the trachea to themselves. And if it's being pushed, the things that can push a trachea away from the side of the pathology are pneumothorax, where there's what do you call it? Air accumulating in the pleura, or if there's pleural effusion, or a large mass that is growing in that part of the lungs, it will push the trachea away. And others that may not necessarily be indicative of where the structure is where there's a mediastinal mass, or when there's a tracheal mass, when there's a mass in the trachea itself, or when there's kyphoscoliosis. scoliosis. All right, so important to note. Last year, this was came in their exam. Okay. So I need someone to quickly comment on this chest X-ray for me right now with regards to the trachea. Yes, quickly. Hey, where's everybody? Okay, let me call names. Okay, Solomon Ade. Can you please comment on this X-ray for me? Hey, where's Solomon Ade?
Okay, so with regards to the trachea, I could see it very slightly deviated. I'm here. I'm responding. Sir, please, can you hear me?
Okay, I heard it's deviated to the right. Good, I agree with you. Well done. So
Thank you.
this trachea is deviated to the right. Yes, we can also see that it's coming down and then it moves straight away to the right. Okay. So from what we just discussed from the preceding slide, I want let me call one lady. Ernestine Apreku. From what we just mentioned on the preceding slide, can you tell us what are some of the reasons why this trachea could be deviated? Quickly. Ernestine, we are waiting.
Please, if there is an infection, it can cause it.
I don't think we mentioned an infection. I'm talking about the previous slide. We mentioned the reasons why the trachea could be moved to the left or the right.
Then my network was not stable. So some of the slides I missed them. I just moved to another place right now. So I was going on and off.
Mamina Dodge. You let me find someone else. Mami, after that, Asafo Boache.
So I think so. It's being pushed.
Usually, you need a history and examination, okay, to be able to make ascertain for a fact, because this one is not so clear what it might be. That's why I made it broad. Now, what are some of the things that could cause a push or pull? So just give us some.
When pressure builds up in the chest cavity.
Oh, but we've just gone through. That's why I want you to mention them. Okay, maybe last minute, can you help? Is Mabel on the line, or she has joined and has put her phone somewhere? Hey.
Hello, sir. Please, I'm driving. I want to park and then contribute, please.
Oh, you're driving. Okay,
That's fine.
Let me get someone else. Sylvanus, continue. Mr. Sylvanus, can you help us? What do you think could be some of the reasons why this trachea is deleted? Yo, because of time, let me just go. I see that people. All right, so we said that the things that could cause a trachea to be deviated to the side of the pathology are atelectasis, that is the pull factors, atelectasis, agenesis of the lung, pneumonectomy, or pleural fibrosis. The things that could push the trachea away from the side of the pathology. These are the push factors, would be a pneumothorax, a pleural effusion, a large mass. Just take note. All right. Okay, so now we move on to the mediastinum and the heart. So as I was saying, the structures in the middle of the heart are largely the heart. And that whole space is called the mediastinum. So these are some of the structures that you find in the mediastinum. And the mediastinum is basically the space between the two lungs. So you can see this lung here on the, this lung here on the right, this lung here on the left. And you can see that the space in between them is what you refer to as the mediastinum. And the heart is a major component here. The trachea is a major component here. So I can simply ask you, which of the following structures are found in the mediastinum? Okay, you can mention some of these things here. All right. So we have the aortic arch. The trachea, of course, is champion here. The superior vena cava, bringing blood flow from the superior parts of the body, will also be here. The aortic arch is also there. Okay. And the trachea is divided into the left and the right main bronchus, and they also break further into other bronchi. Okay. And the border of the left border of the heart, the right border of the heart are all here. There are lymph nodes running all the way through. And of course, these are not mediastinum, but let's remember what I said about the costophrenic angle and the cardiophrenic angle. All right. Now, the reason I'm particular about chest x-rays are because, as I've said, usually they don't come with reports. And so, because of how simple relatively they are, it's important that every clinician knows how to read them. Okay. All right. Now, so there's the mediastinum with the heart showing. Okay. So all these structures are there. All right. Okay, so this is a lateral view of the heart, okay, which is showing the various, so you can see that it's been divided into three parts: the anterior mediastinum, the middle mediastinum, and the posterior mediastinum. In the anterior mediastinum, the main things you see are the heart. Okay, so this is the heart showing here. Okay, and there's a retrosternal space. So sternal means sternum, okay? Retro means behind. So there's a clear space behind the sternum here, okay? And in the middle, the trachea, the middle mediastinum, the trachea will be there. Remember, this is a lateral X-ray. You shouldn't be talking about middle, what do you call it? Posterior and the rest when you have a PA view, when you are talking about the mediastinum. This is a lateral view. That's when we can talk about the posterior mediastinum, middle mediastinum. Please don't confuse it with an AP or PA. I hope that is clear. Don't when students usually get this as an exam and they turn the whole thing upside down and get 0. Just because they're not paying attention. So please take note very well. Okay. Then so middle mediastinum would have the esophagus in here, would have the arc and descending aorta, and the trachea. We would have the posterior mediastinum having the paravertebral area, and all of these areas contain lymph nodes. All right. So in exam, I could bring this to you and ask you to name various structures that you could find, in the various parts of the. All right. Okay. There's also something that you should be conversant with. So when you see a chest X-ray like this, you should be able to have or visualize the heart in it. So this one, they've used the marker to delineate it out for you clearly. So when you see on the chest X-ray, these are the various areas where you expect these parts of to be. So on the lateral aspect to the left, you expect to see the left ventricle. What you see there is the left ventricle. And what you see on the far right will be the right atrium that will be showing. And then in the middle, you see the middle part will likely be the right ventricle. All right. So these are the things that you see. And on the X-ray, it is the border that you use to delineate it. Where's the border? So this one, for instance, we have the border. This is the border here. Okay, so we are seeing on the left, on the right border here. Okay, even this is labeled here, so I know this left, but even without the left, it being labeled here, I could tell this is a gastric bubble. I hope you can all see the gastric bubble. So I know that this is the left border of the heart, this is the right border of the heart. And I don't know how many of you would have noticed, but this is an unusually large heart. Okay, this heart is too large. So this is cardiomegaly in a child. All right. And so the left border here is more of the right atrium that is showing here. The right ventricle will be somewhere here. Okay. And this section here will be the left ventricle. The left ventricle will be showing up here on the left border here. This whole place is the left ventricle. Usually when the heart enlarges, is the left ventricle that shows. And the superior vena cava also coming from up there. Okay. And the inferior will not show, but it's also somewhere behind. Now, these are the aortic knuckle. Of course, the aortic knuckle can be prominent. I'm sure another X-ray will show it. The pulmonary B, the left atrial appendage, the left ventricle. These are what we've described on the various borders. This is the left ventricle on the left border, the right atrium on the right border. Okay. Right. Now, you realize that on the X-ray, you are able to see. Anyway, who can give me a general comment on this chest X-ray? Quick one, quick one. In terms of the quality of the X-ray, who can give me a quick comment on this X-ray, just on the quality of the X-ray?
There is over penetration.
Pardon me. Come again, I didn't hear you.
There is over penetration of the ring.
Exactly. So you can see that on this X-ray, all the ribs are not showing. So this is a clear picture of exposure. But it's just so that we can see the ends here. That is why this X-ray was used. All right. So the whole of the right lung is here. The whole of the left lung is here. Now, the medial aspects of the lungs are approximated to the mediastinum. So the borders of the right upper lobe of the liver will be attached here. Middle lobe will be attached here. Same goes for the left upper lobe and the lingula. I hope you know what the lingula of the lung is. It's that small part that comes to cover the lower aspect of the part. Now, I mentioned that we can determine objectively whether the heart is enlarged or not. So I can just, you can calculate objectively and determine that it's large, and everybody would calculate and come to the same conclusion that the heart is enlarged. And we use the cardiothoracic ratio. Cardiothoracic ratio. Now, for a normally sized heart, the cardiothoracic ratio should be less than 0.5. Should be less than 0.5. And this is how you calculate it. How you can see my cursor again. Very important. Take note. Last year, they did get this in exams. Okay. So what you do, if you want to calculate the cardiothoracic ratio, is that first of all, you take your ruler and then measure the whole of the largest diameter of the thorax. And you measure this or get this by measuring, usually the thorax is largest at the ends of the diaphragm. So you measure the end of the Costophrenic angles, the very end. Okay, so you measure the inner border of one rib, the inner border of the other rib here. Okay, the inner border here to the inner border here. Okay, so that is what you use as your denominator. So this will be your denominator. Then you rule a line right through. These are imaginary things we are talking about. So you can, if you have a pencil, you can maybe make a slight mark when you have the X-ray. I mean, we are talking about having a physical X-ray with you. So you try and demarcate the very middle of it. You can use the medial ends of the clavicle to determine the midpoint, or you can go through the spinous processes to be sure that you're in the midline. Now, when you have a line in the middle, then you measure the longest diameter of the heart border from the midline on the left and on the right. So you realize that if you take the left side of the left border of the heart, okay, the left border of the heart, the longest diameter from the midline is not here. And it is not here, but it is rather here. This is the longest border. Do you get it? So you measure the longest. Okay? So that will be one of your numerators. Then you measure on the other side too, the longest distance or the longest diameter of the border of the heart to the midline. Okay, so midline is the longest part. You realize that the longest part is not here, and it's not here, but it's rather somewhere here. So you measure midline to this, the longest border, midline to the longest border on the left and the right. Then you add A and B, and you divide by C. And your value, if your value is less than 0.5, then it means that there is no cardiomegaly. However, if it is